Dr. Gauri, over to you. You can start it. Yes, sir. Please, please, sir.
Good morning to everybody, and then let us wish Rajesh. Yesterday he had this wedding anniversary. God bless you and your family.
Thank you so much for the blessing, sir. Thank you.
Good morning, all. Thank you all for coming on Sunday morning. What we are going to do in the next 1 hour 15 minutes is, we have some of the finest teachers, great minds over here in the stage. They have mentored hundreds of students in the field of diabetology. At the same time, we have seen them in the journal clubs. Whether we are prepared or not, whether the presenters prepared or not, the teachers are always prepared. They come very updated, they are very point, very crisp, very knowledge in discussing all those things, amazing knowledge. At the same time, they have a huge practice also. So outside their academic hours, they have such a huge practice. So it is very rare to find such a great blend of academic knowledge, being updated, and at the same time having an enormous practice. Now in the 1 hour 15 minutes, we are going to present a case. It is not a case presentation that we are going to present and they will be asking us questions. Rather, it is not going to be an interview also, like we are going to show the cases and asking them what they are going to do. Neither it is going to be panel discussion. We are just present a case, which we all see in the day-to-day practice, and ask their opinion, ask how it could be managed, what mistake we would have done. At the same time, we will be devil's advocate also, asking some questions which you will be embarrassed to ask in this forum. So that is what we are going to do. We will seek their knowledge, wisdom, and their updated information on how we could have done better, what had gone wrong, and what could have contributed, and how we have to stand at this point of time. This is the next 1 hour 15 minutes. Like the kids who are very enthusiastically going to the class, we are also very enthusiastically approaching this case in an open mind to know their opinion. Dr. Rajesh, we have a case to show.
Yeah, I'm ready with the case, but before going to the case, let me profusely thank GVK sir for giving this wonderful opportunity. Let me also take this opportunity to thank Professor Venkatraman sir, because the whole concept, this entire concept of journey with a diabetic subject is actually the brainchild of our Venkatraman sir. So let us thank him. Let's go straight away into this case. Yes. So now, what we are going to see is a very, very average patient, very normal patient which we usually see in our day-to-day practice. You can see a 46-year-old male, absolutely asymptomatic. He doesn't have any complaints. If you look into the profile, he works as an executive in a private firm, and again, obviously, he has sedentary lifestyle, and he is having an erratic food habit. Initially, 3 years back, he was detected to have pre-diabetes. We do not know the rest of the details. He was not under good follow-up, it seems. And if you look into the family history, you can see he has a very, very strong family history. First-degree relatives, most of his first-degree relatives have history of diabetes, and they also have history of coronary artery disease. But in spite of all these risk factors, this particular person continues to smoke, and you can see he smokes at least 5 to 6 cigarettes per day. And you can see he also consumes alcohol rarely, and most of his family members, his father, his mother, his siblings, all of them has advised him to do a complete blood check, asked him to do a master health check, but he did not listen to them. He was not at all bothered it. But what happened one day, his wife asked him to do the blood sugar. So you know that he is an average Indian married man. He has no other option, just like myself and Gauri and all of you sitting here. When wife says no other option is there, so he obliged to do a blood investigation.
Nobody has an option.
Yes. So, yeah. So, if not to prevent cardiovascular disease, at least to prevent unfavorable consequences at home, he did a complete checkup. So what happened, you can see. Yes. So this actually happened somewhere in 2015, early part of 2015. So when he did a complete blood investigation, what happened, you can see, you can see the blood pressure is 126 by 80, BMI is 29, obviously he's obese, and fasting is 165 milligrams per deciliter, postprandial is 283 milligrams per deciliter, HbA1c is 8.4, for discussion's sake, we are going to be glucocentric. We should not, for treatment, we should not be glucocentric. We have to consider the patient as a whole, but the discussion is going to be glucocentric here. So I'm not projecting all the other values. The complete blood count, the RFT, LFT, lipids, thyroid, ECG, everything. Whatever has to be investigated was done for this patient. Imagine everything is within the normal limits, but the blood sugar is 165, postprandial is 283, and the HbA1c is 8.4. So what we have now is a newly detected type 2 diabetes patient. So in this context,
so are you going to treat him with any drugs? So a high risk profile patient, family history strongly it is there. The sugars are not under control, Rajesh. HbA1c is about 8.4, fasting is not controlled, postprandial is also elevated. So obviously it looks like we have to
intervene him.
Any pharmacotherapy. So that's what we do know, like he smokes, he has so much of risk factors. Now we will ask the discussion from Madhavan sir. So in this patient, now the moment patients are diagnosed, they go to YouTube and that is where they keep themselves updated. So the moment you open any video on YouTube, it says like reversal program. You have to open first video, from second video, all your pop-ups are going to be on reversal of diabetes. So in this context, are we going to tell this patient who is obese with raised parameters and now 5 years data, 10 years data, so much of companies coming in, so are we going to tell him about enrolling to a reversal program, or are we going to tell our patient that he has to undergo some lifestyle management at this stage before putting on pharmacotherapy, or are we going to tell only lifestyle management at this stage, sir?
Thank you, Dr. Rajesh, and thanks, Dr. Vijayakumar. I think you told me that, you told the audience that he was a pre-diabetic previously. Yes, and was not following up. I don't know how many years he was a pre-diabetic, whether he had any medical consultation during that period, he was following any lifestyle during that period, but obviously he was not. So he has progressed to frank diabetes. I think the stage has reached where lifestyle alone is not going to be helpful, at least in this present situation. So obviously he has a very strong family history of type 2 diabetes, very strong family history of cardiovascular disease, and his lifestyle is very, very obviously not sticking to the prescribed lifestyle modification. So definitely lifestyle, without lifestyle no diabetes treatment. I have to advise him with lifestyle modification, but I think I will put him on a drug, taking into consideration that he has the smoker, the blood sugars are already 8 plus, average sugar is 8 plus, and he has strong family history of atherosclerotic cardiovascular disease. Definitely, I will choose a oral agent, at least temporarily. So once probably he sticks to
obviously
lifestyle,
we have to put him on an oral agent, but the confusion what we have is that, does lifestyle really work for our patient? Does adopting a healthy lifestyle, adopting a good diet plan and doing good physical activity, really does it have an impact over the metabolic profile? That's the thing we wanted to know.
There is absolutely no question about it. Lifestyle, including medical nutrition therapy, physical activity, cessation of smoking, moderation of alcohol, everything definitely is going to help this patient. But that alone, in my opinion, is not going to help him at this stage. I will definitely like to put him on a drug, taking into consideration all the other parameters like comorbidities and all that. So if you ask me, if you are going to ask me which is the drug you will choose now,
so that we will
later. Okay, yeah. So the answer to your question is yes. Along with lifestyle, I will definitely go for oral.
One question is, if we start him on drugs, we will take it from Vijayakumar sir. If we start him on drugs, probably he may be compliant to the drug but may refuse to undergo lifestyle changes. So this dilemma will be always there. So let me see like whether lifestyle will be working for him or not.
Okay.
So
see, the whole issue is that, the original thinking is that put them on lifestyle modification. All the, guidelines and the algorithms, till 3 years ago, they used to say that, okay, put them only on lifestyle modification. And if they fail to do so, put them on metformin. If they fail to do so in metformin, second drug. If you fail to the second drug, you add a third drug. See, this means the system of going is based upon failure to treatment. This is nothing but reactive therapy. your failure to treatment is the most important thing. So I think we need to change, as Professor Madhavan said, we have to change the mindset. That is, we need to be proactive, anticipate, and look at the history, like what you have explained, that he had a family history of cardiovascular disease. So I think, that the attitude, even that American ADA, ESD guidelines and all changed about 3 years ago. They said if HbA1c target is not your type, like more than 8, start a combination therapy in the beginning itself. What combination therapy? I think you are going to discuss
Yes,
it.
yes,
So it is
yes.
definitely essential to start a therapy, preferably combination therapy.
Yes.
Now, what combination therapy is the main issue is that now the philosophy of therapy is entirely changed. You no more treat hyperglycemia. You need to address the pathophysiological factors which cause hyperglycemia. That should be paramount in our mind, and then do that.
Yeah.
To say that if you start him on any pharmacological therapy, he will not adhere to lifestyle. It's not, I don't think I agree with that.
Because invariably he has to, whether he
Lifestyle, yes,
takes,
you have to emphasize.
yes, correct.
Without lifestyle, no pharmacotherapy is going to be useful. So we have to emphasize it's a complementary to each other. So if we assume that if we give oral agent, he may not stick to lifestyle, I think that will be a failure on our part to motivate the patient.
No, if you see all the guidelines, I would wish all the practitioners here to look into the guidelines. Guidelines paramount is lifestyle modification, and then comes other things. In fact, even that latest ADA-ASD guidelines is really good. In fact, they have now come, once upon a time they used to be American oriented. Now today they are all, they are global oriented nowadays actually. In fact, they have introduced even alpha glucose inhibitors in the last year actually, which they never did that for almost 25 years.
Yes.
So I think people are changing, and then I think the concept is changing, and I think even RSSD guidelines will say the same thing.
Yeah.
For discussion's sake, this person is an obese person. Is he not a candidate for intensive lifestyle management and reversal?
Obviously, that was the thing we were asking.
Without drugs, I mean.
The issue is that he was a pre-diabetic, as he was explaining.
We missed the bus at that time.
Yeah.
Yes, sir.
When he was a pre-diabetes, he should have been on intensive lifestyle. We missed the bus now. Even now, he otherwise asymptomatic. Is there a role if he goes for intensive lifestyle changes with drastic reduction in blood, weight, and probably his HbA1c could be reversed to less than 7. It is possible.
It is possible, sir, but
Yes.
practically how far we can achieve this in every patient, that's the question.
No, the motivation. He was
Yes.
what trying to say is that you should motivate them to
Yeah.
do that. If he gets motivated, I don't know what your case is, whether he is
Yeah.
a motivated person or not. The other argument that what is a very pertinent point what Professor Moses has said, that you go for
Intensive
lifestyle modification.
alone. Medical
Or, sir,
bariatric.
can you think that probably we can put medication in such a way that
Or
you
as
reduce the weight initially?
Parandaman sir says, can we just try 2 weeks of aggressive by the time like
2 weeks is too
2
small.
weeks. See, he must reduce at least 10% of his weight.
aggressive therapy which Roy Taylor advocates for 2 months, can we just try for 2 weeks and see whether he is
3 months. 3 months.
Recommendation today for reversal is you have to reduce 15% of your existing weight.
Not
So
50,
10 to 15%.
25%. 25%.
25. So one of the recent studies in UK, they included patients who have been diabetic for even 8 years, 9 years. They have shown reversal,
because
but the authors himself said that
he's
this
grossly
needs long
obese.
steps.
See, the problem is when you wait for 2 weeks, with what parameter you are going to judge whether it is reversed or not?
Too short a time.
Actually, if you see that guidelines, as Professor Madhavan and Professor Annamas are telling, if the duration of diabetes is less than 5 years, you need to lose about 10 to 15%. If it is more than 5 years, you need to lose 25%. This is the usual. It does not mean that this is the guideline, but generally it is felt that if 5 years, less than 5 years, and minimum medication like only one metformin or something like that, if you lose 10%, the possibility of remission in diabetes is possible. Friends, don't get carried away by reversal of diabetes. It doesn't never happen. It is only remission. If anybody says that reversal, don't trust.
They play with the
Please don't get carried
terminologies.
away.
They play with
We
the
can have only
definitions.
remission, but no reversal.
Yes.
No, what I want to know is, why not put him on a oral agent?
Obviously,
Along
we are,
with it, lifestyle. Once he achieves good weight loss, the glycemic control is very good. Withdraw the drug and see.
obviously
is
that could be
also
the
a
better thing, because
better option. Yeah.
whether you're going to give pharmacotherapy or not, a lifestyle is the mainstay. It is the foundation of any diabetic treatment. So that is, we are going to start. Okay. So with this patient, when you are going to start
If we
a
are
drug,
going to start an oral, why don't you give 3 months time with intensive weight loss management? Suppose
obviously when the patient is motivated,
comes to below 7, sugar comes to normal. He could be maintained on lifestyle modification without starting drugs for a few months or even sometimes a few years.
You know, the reason why he's asking is that there is no target in
correct,
addiction anywhere.
correct.
So
And he's
he has,
asymptomatic.
you know, he has finished a few years with pre-diabetes. Why not wait for 3 months? That's what he was saying.
No, it's
Okay.
more for discussion. The
I know.
possibility is also there.
You know,
Paranam,
friends,
We
let me
have,
tell
we
you.
have an
The-
option there,
No, no.
but as the Hong Kong
Rajesh.
study of 2023 says, like such sort of
Guidelines
reversal
are
happens in
different.
only,
Look,
in a real life data, shows only in 67% of the people they fail. It happens only in 34% of the people. Provided our patient is picked up at that stage, he is motivated, then we could have opted for that option also. Having our patient is not motivated, as Madhavan sir said, like we will go for aggressive lifestyle management with a drug.
So in this context, when we are going with a drug, already GVK sir said that we are not going to start with the monotherapy anymore. What we need to do is addressing hyperglycemia is not an important. Hyperglycemia is just a metabolic manifestation of diabetes. What we have to actually do is that we have to address the pathophysiology which is actually causing hyperglycemia. In that way, if you are going to target multiple pathophysiological defects, what we will get is that we will get an effective HbA1c control, and that HbA1c will be, that control will be durable. So in this context, we are going for combination therapy. We are not going to go for monotherapy. In this context, let me ask from GVK sir.
No, no.
Yes, sir.
What I would like to say about our friends here is that diabetes is really heterogeneous, in the sense the way it occurs, the way it progresses, the way it responds to the treatment, the way the physician thinks as well,
Yes.
caregiver. So everybody is right. Only thing is you need to particularly take the situation of that particular patient at that time, and then all the opinions are, everybody is right
Correct.
and nobody is wrong.
Absolutely.
GVK sir, can I add something?
Yeah, please, Dr.
I think
Shruti.
as you said, everybody is right here. I mean, I don't think there is a right answer to your question.
Ob-
Dr. Rajesh.
obviously.
But I think what we should do is we should have this discussion with the patient, give them the choice and see what they prefer. I think as Dr. Moses sir said, in 3 months, it can go into remission with motivation, as you said, right? So I think that's a discussion that we should have with the patient, give them all the options, stopping the cigarettes and proper sleep schedule, maintaining a chart, or even going on a continuous glucose sensor if they can afford it, to see the trend in the sugars. All these can be done to see if it can go into remission without medications, just with lifestyle, sleep, addressing the stress, and stopping the cigarette, etc. So I think there's no right or wrong.
No. It's
wrong
not like this,
quest-
Shruti. The discussion is whether you would like to be there or you would like to start a therapy which has got a benefit in weight reduction and then stop it. That is the discussion.
That's what, sir. I think we should give that discussion to the patients and see what
Obviously,
they would
we
prefer.
have to
I
involve
would-
the patient
I would
in
say
decision
most
making.
of the patients would prefer lifestyle
What she means
changes
is
if they are
even
really
the option
motivated.
has to be given to the patient.
Yeah, obviously.
I think
The
it's
point is-
not something that, I mean, as you said, all three of you, have their own preference, and I'm sure we all practice in a different way. I think it has to be a discussion that we solve with the family and the family member.
Your point is well
and
taken.
As Dr. Parandaman sir said, it can be, you can wait for 3 months and see what happens with lifestyle changes, and that's my opinion.
Yeah,
I
you're,
totally
you're
agree with you, madam. I
Yes.
think without dialogue, no patient is. We
Correct.
are not going to be successful.
Correct.
Complaints will be very poor. Dialogue has to be there. It has to be reinforced during every visit. It is not just one time. It has to be there. But another thing I would like to know is this patient is having a very strong family history of diabetes,
Yes.
atherosclerotic cardiovascular
Cardiovascular
disease,
disease.
smoker, now diabetic, obesity. Are we looking at the cardiovascular status? now?
Yeah, we that has been evaluated. Yeah, we have to do it. We have to do it. That has been
So that
evaluated.
again will decide whether
Yes.
we are going to give him only lifestyle
Absolutely,
or
absolutely correct point. Well, yes. Please, sir.
Sir, shall I add? I think everybody is right because you are on the top, you are the teachers, you are teaching. So it's only for discussion because he is asymptomatic and he is obese and smoker. All risk factors are there. If you are able to adequately motivate, stop smoking, obese, and if you reduce the fat, the abdominal fat, the liver fat comes down, insulin resistance goes off. Just reducing the weight. And ideally motivate to reduce the weight because it's asymptomatic. He won't be sometimes adhering to the treatment also. We will give short therapy.
No, the thing is that if you see what he has said, is that he never went for even investigation.
Yes.
In spite
But his
of the
wife's
family
request,
telling,
he did this
only
fast
wife
checkup.
she told he went there. So he's not a motivated guy. That is a problem.
Yes, that's a
Yeah.
How far you can motivate them? This particular person is a
motivate.
Yes.
That's a,
but see, and I think you need to educate the wife to motivate him. That's the only thing.
Okay, for discussion. So for discussion's sake, what we will think that this patient is, imagine this patient is not that very motivated. So what you do, you are going to start a pharmacotherapy here.
You have talked to the patient, he
Yeah.
decides on medication.
Yeah, yeah.
So in 2015, we didn't have so much of reversal data.
Okay, yeah, probably. So with all these things, what we are going to do? Yes, remission. The time and all,
So remission data,
Yeah.
okay.
So now imagine we are going to start, for this patient, we are going to start a pharmacotherapy, and we are not going to start with monotherapy. When it comes to combination therapy, let us hear from Dr. GVK sir. Are we going to start this patient with a dual therapy or a triple therapy? In case if it is a dual therapy, which two drugs you are going to start? So this is, let us hear from you, sir.
I would prefer dual therapy here because you don't need to go for triple therapy straight away. Double therapy is good enough, and then looking at his BMI, looking at his family history of CAD, I would like to put them on a combination of, my favorite is metformin with SGLT inhibitor.
Okay. Any other opinions from our experts
I
here?
totally agree with Dr.
Okay.
Vijayakumar.
Okay.
I think this should be a combination of SGLT with metformin. If there is any specific contraindication for any one of these two drugs, I will go for DPP-4 inhibitor.
Fine, absolutely.
No, as he said that there are certain advantages of going for a combination of DPP-4 with metformin. We just look at the verified trial which has come. A fantastic trial. In fact, those people, the thing is that one group of people have been put on metformin DPP-4, that is vildagliptin combination.
With monotherapy.
The other group put only metformin and then followed them up. What has happened was that those people who are in a combination therapy in the beginning, they did not get rescue therapy up to 2.5 years.
Correct.
And most of the people who are on monotherapy had to go very early, at least 50% before that, go for a combination therapy. Now, there's a catch is, in this international study, there are 320 Indian diabetics. You know how Indian phenotype response is a very, very important thing. In these 320 patients in the verified trial, can you believe the same group of combination therapy, the other populations had required about 2.8 years for further rescue therapy, but whereas in Indian population took about 4.5 years. So I think we have to keep in mind our Indian population,
Correct.
Indian phenotype, and also think about this. They're very important actually.
Yes.
We need to treat our patients in our own way, how they respond.
Yes, sir.
Having started them on dual therapy, sir, now we will just ask Anand Moses, sir. Good morning, sir. So having started them on dual therapy, now, sir, do you think that this patient who is 46 years old, who has a strong family history, and he continues to smoke, so do we have any role on usage of statins? His LDL is now 120 milligram per deciliter. His triglyceride is less than 150. So are we going to start along with this dual therapy on diagnosis? Are we going to put him on aspirin or any other antiplatelets, or if his LDL is 120 with the triglyceride normal, is he going to be co-prescribed with a statin?
Yes, of course, his LDL is 120, he has to be put on statins.
But imagine in this patient,
I have my own reservations about aspirin as primary prevention is a very controversial thing. Whether it is really useful or not is a big question. There is always every few years there is a change in thinking whether aspirin is useful or not. But definitely statins are a must.
So now, in case if the LDL is 80, are we going to again, so around target of 70, so it is between 70 to 100, can we put a statin over there also, sir?
No, why do you want to put a statin?
For primary prevention.
So
still
I
we
don't
may
think there
about
is a-
Age
Recommendation
46.
today is lower the better. So in fact, some of
No,
the
but
recommendation
when
is
they-
52.
At the time of
So, sir, the question will
Screening.
remodify like this, sir. Irrespective of LDL, will the patient be put on statin?
No.
For primary
The thing-
prevention.
No, the thing is that, we should differentiate what a cardiologist and what a physician, primary physician does it. See, they wanted to bring down the LDL to less than 70, sometimes even less than 40
55.
after an event. Here you are not treating after an event, you are trying to treat before an event. So I think the guidelines will change before the event and after the event.
Gauri, he has a strong family history of coronary artery disease.
Yes.
Why don't you wait and screen for any coronary artery disease? Do a
Sir,
stress
Imagine
risk
that has
score
been
is good,
screened,
sir.
sir. Yes.
Saw the risk score, it is good. ECG is normal. Treadmill is normal. We have screened that.
And
sir.
with the LDL of 80, I wouldn't think of starting a statin as a...
Age of 46, strong family history, smoker, sedentary lifestyle. With all these things, do you still think we will not start him on primary prevention, sir?
You said risk score is normal.
Q risk score we did, it is normal, sir, based on. But he has a very strong family history.
How can the risk score be
Risk
normal?
score
With
is,
so many risk factors. Strong family history, obesity, sedentary life, smoker, diabetic. I think.
Okay, sir. Risk score is elevated, sir. So, but LDL is normal, sir. So, still, do we have a...
If you say if it is 120, I will definitely put him on statin.
Sir,
I try to bring it down.
Even for a... Yes, sir, please, sir.
So good morning. Sorry I came a bit late. I apologize to the chairpersons. And this was our workshop which we did in a meeting sometime back. Many people were enthused, so we thought we'll have a repeat of this. Now, I thought one of the ADA guidelines is, I'm not too sure it's captured in 24, irrespective of the cholesterol level, all diabetic subjects more than the age of 40 should be on a statin. The number comes when you titrate the dose of statin. Now, I think even for primary prevention, the LDL target is 70, not the 100 which we used to believe. So, this case calls for initiation of statin, and certainly if the target is not going to be 70, certainly a high intensity or an addition of ezetimibe. That is my take on this.
I request all our participants to go through the Canadian guidelines also. They have given clearly the usage of statins between the age group 3 to 13, 13 to 20, 20 to 30, 30 to 40, like that. Please read the Canadian guidelines also.
there is a hesitation among the practitioners that we don't need to use statins if the LDL is 80 or so. So the message has been conveyed.
Another area, you asked about aspirin. Again, this, as Professor Moses said, it's a very controversial area. But again, in this case, I will definitely calculate the risk factor. And if there is family history of events, especially young age, I will definitely put him on a small dose of aspirin.
After explaining the risk involved,
Yes. After explaining
this
the
patient needs definitely, because pre-diabetes for 3 years, and now the A1C is 8.4, and family history of CAD, smoker, it's an absolute indication for initiating the patient on aspirin, after explaining the pros and cons.
No, I mean, in fact, we had to take a leave from the trial, no, that Denmark trial. See, they have taken that, that apart from taking care of all the coma, Steno trial, Steno 2 trial. So they have taken, they addressed all the comorbid conditions and put everybody on aspirin in that case actually. But whether it is the aspirin which has reduced the 58% reduction in cardiovascular disease at the end of 5 years, or it is because of the comorbid condition management, nobody knows.
So again, the message is very clear. Any diabetic individual above the age of 40 years, along with the diabetic medications for primary prevention, you have to give at least statin for primary prevention. This is the message is very clear. So with this, Can we move on to the next slide? Can we just start? Can you just tell what happened to the patient?
He was given a detailed counseling. He was advised to do physical activity as said by our teachers. He is undergoing physical activity, motivated at that point of time. Adequately we counseled the family also. So in 2015 we had a slight, we were not so confident as we use SGLT2 inhibitor. At that point of time we were confident of DPP4 inhibitors. So he was given a fixed dose combination of metformin with sitagliptin 2 times a day. And in March 2015, when he came, his blood sugars are under control. Again, he came for a review after 2 months. Again, the sugars are well under control. Again, he came after 3 months. August, it is well under control. December, again, like all throughout the year, he was well under control. Like all good motivated patients in our care, he was all having a good compliance for about 6 months to 9 months. So he predicted his sugars are going to be well under control for the next all his life. So like all good patients in our practice, he also after 1 year, he stopped taking medicine. He stopped coming for the hospital because he thought like with this medicine, he will do all throughout his life. He doesn't need any medication at all at that point of time. So he stopped coming to the hospital, he stopped checking the sugars. Again, he went on sugars of fasting 176, postprandial 207, HbA1c of about 8.3.
So this is what we usually see, no? Well-motivated patients, initially they become motivated, we think the job is done, we will be very happy, but unfortunately what happens after a period of 1 or 1.5 years, they don't come for follow-up, they come back after 2.5 years or 3 years, and you can see the HbA1c is again on the higher side. So this is what we see. So let us hear from Professor Madhavan sir. In this particular patient, you can see 1 year, 1.5 years, he was under good control, and after 3 years, he's coming back, no follow-up in between. The HbA1c is again on the higher side. So what are we going to do for this patient? I just want to ask from you, are we going to restart the same medicines, keeping in mind this patient was not taking the drugs, not doing physical activity, not compliant with the diet advice what we have given, keeping in mind with all these things, are we going to start the same dual combination therapy along with lifestyle, or are we going to intensify the therapy by adding a third drug? What drug we are going to add in case if you are going to add, that we will see. But really whether this patient needs intensification or whether the same drugs can we start. This is what we need.
I don't think I will intensify therapy at this stage. After all, he had not been on either lifestyle modification or he has not been compliant with the drug pharmacotherapy. So if at all I need to start pharmacotherapy, I will start the same drug. I won't intensify it at this stage. I will not assume that his beta cell reserve has worsened and requires a third drug.
So again, he needs all those puja, bhajane, everything we did for him at the initial part. So he has to be motivated again with the same drug. We go with SAR's advice. So having done that, is there a role for any other drug? So can we add SGLT or?
He is already on SGLT with.
No, he's on a DPP4 with
metformin.
Still BMI is the same, still weight is the same in that context.
Okay, I think if you don't mind, and I think that that we need to see that diabetes is a progressive disease. Number one, diabetes is never the same each and every time they come to you. So I think as the disease pattern changes, we need to change our strategies. Very, very important. So what happens is that here you can see that he's already on dual therapy, not under good control. I have a feeling that he may not, this particular patient, I'm not talking about other patients, this particular patient may not be that motivated to continue the same DPP4 and metformin, and then he'll be under good control. Instead, I would like to continue that, add an SGLT inhibitor to this.
No, he has not taken the medicine.
He is, he's in every
Non-compliant, sir.
Non-compliant.
No, but
at times he takes, he skips.
He misses 15 days, 10 days, then he starts taking non-compliant, sir.
No, even then, I think now that you said that 2014, the SGLT was not available at the time.
Now it is 2018.
Now it is available.
Yes.
I think you should go for a different combination.
Sir. So we will now move on to Anand Moses, sir. Okay, for this patient, for discussion's sake, let us presume that he is on lifestyle.
Okay.
He is on lifestyle. His drug compliance is also good. But he is coming with this blood sugar of 176, 271. With a HbA1c of 8.3. Now he came to us in 2015, pre-diabetes was 2012, we are seeing him in 2018. So what would be the next strategy for this patient? He is now compliant, for discussion sake. He is compliant, his drug adherence is good, his lifestyle is good. So what would be our next step?
Can I add a tricky question here, if you don't mind? See, sir, you said you are going to add an SGLT2 inhibitor now. Okay. Suppose, initially, if this patient is already on a 3-drug combination, in that case, will you intensify or not? In case if you want to intensify, will you add a 4th drug or not, or you will go for insulin? So we want to hear it.
4th oral agent, you mean?
Yeah, 4th oral drug, or if you said if the patient is on
I think you are
2 drugs, you are going to add a 3rd drug.
you have confused the patient as well as me. If, as you say, the patient is compliant now, and in spite of sitagliptin and metformin, still his blood sugars are not under control, definitely there is a role for a 3rd drug, and ideal 3rd drug for this place would be a SGLT2.
But suppose if the patient is already on 3 drugs, SGLT2, DPP4 with metformin, now if this is the scenario, are you going to add?
Or we will take it this way. So he is not on SGLT. So SGLT was costly at that point of time, 2015. Generic SGLT were not available. Can I add sulfonylurea at this point of time? So is there a role, even in this SGLT2 era, after this metformin and sitagliptin dosage, is there a role for sulfonylurea?
If the patient refuses insulin, probably we could try a small dose of sulfonylurea added to this, because it's going to be a secretagogue.
I gave a lecture on the place of sulfonylureas. I think there is a place, but in this patient, I don't think I'll use sulfonylurea.
I would motivate him for insulin.
Yes, basal insulin is a good choice.
After 3 drugs, I would motivate for
definitely,
insulin.
I'll give him a dose of glargine in the night and try to control the fasting and see.
Dr. Gauri,
Yes, sir.
this patient is smoking 5 to 8 cigarettes per day.
Sir.
He's spending money for purchasing cigarette. Why not he pay money to purchase?
Sir, he's willing to pay another 1 packet of cigarettes, but not willing to pay SGLT, sir. He's willing to take rava dosa every day in the hotel next to him, but not willing for lifestyle management.
Motivate him in such a way, let him divert his mind towards purchasing and
Then he will say, you reduce the cost of your consultation, sir, I will purchase SGLT.
Yes, the SGLT2 is so cheap now.
It was in 2018. It was in 2018. Generics were not available.
So Anand, Madhu, and Vijay, can I? So I think what Gauri wanted to ask was, we have had a gap of 3 years with respect to the follow-up and the treatment. So if you look at this patient, there are 2 scenarios. One is what actually happened when he missed everything. HbA1c is 8.3. Whether you will be able to recapture the deficit in the HbA1c with the same drug combination of 2 drug molecule, which I believe is unlikely.
Yes.
Because
Yes.
you would like to push him to 6.5. A young individual without much of a problem, certainly 6.5 would be the target. So 3 drug combination would be. On the other hand, if he had assumed that he had been compliant with everything, as we have seen in the day-to-day practice, even good follow-up and good compliance with medicines, there is an escape of glycemic control. I think that was the scenario that you wanted to explore with respect to. So I feel with 2 drugs, the deficit is almost 1.8, maybe a 3rd drug, and on top of it, a basal insulin, or replace the DP4 inhibitor with a GLP-1 receptor agonist, if he is, as you rightly said, when he can spend for 5 cigarettes, why not he spend for a molecule? I think at the mind of the clinicians, the options are many, but for the sake of some amount of semblance of approach to a patient with this type of scenario, I think restart this patient on 3 drugs. I think if you agree, if there has been a gap in the compliance, on the other hand, if he has been compliant, on top of a 3rd drug, an SGLT2 inhibitor, maybe as Professor Madhu rightly said, substitute the or add a SU in a small dose and wait for the response, and sooner initiate a small dose of insulin. And the 3rd option will be replace the DP4 inhibitor with a GLP-1 receptor agonist, because we know the advantages are huge. The glycemic capture is so good with a GLP-1 receptor agonist if the patient can afford and if you feel it appropriate. So this will be my thought for this case in these 3 scenarios.
Sir,
Yes, sir.
So,
I am from some obstacle areas. I think India lives in villages. Agree with me? So your lifestyle should be oriented towards village lifestyle. See, can I share my experience? The past 15 years.
Sir, we will discuss the case and take your...
So far you are pharmacocentric.
Sir.
I am going to be lifestyle.
So that we will take later, sir. We will,
some other time.
Yes, sir. We will, at the end of this discussion, we will
share
your experience
in lifestyle.
Sure, sir.
I am not going to talk about anything pharmaco.
Exactly, sir.
Thank
we
you,
will take, sir.
Absolutely, sir.
Now that Venkataraman sir has briefed that yes, we can go for triple drug also. Now let me talk devil's advocate. So in clinical practice, it is not uncommon for us to see a fixed dose combination of metformin, sulfonylurea, AGI 2 times a day with the DPP4 and the SGLT2 inhibitor. Very simple, give it 2 times a day. So the patient is put on already on 3 drugs. He is coming with exactly the three readings. Highly, he is not at all willing for insulin and already on 3 drugs. So it is easy, like give two drugs, metformin, sulfonylurea, AGI 2 times a day, DPP4 SU, SGLT once a day. So what is fundamentally wrong in my thought process that I should not give this combination? The patient is compliant, affordable, he is very good, he is able to take it. Now, am I wrong in starting this combination to this patient? Sir, can I take your opinion?
You are very right. It's nothing wrong. This is the practical thing what we do in our practice. Let us think about being practical and pragmatic. I think what you said is right. Motivating a patient of insulin is better than before, but it is still difficult. And as you said that, as Dr. Venkataraman said that, why not we try a small dose of sulfonylurea? What you said is very, very pertinent. You should go ahead with that.
Sir, 5 drugs.
No, 4.
No. So 5 drugs, sir. I am asking.
He was asking about 5 oral drugs.
AGI, DPP, SGLT.
No, Gowrishankar, if the duration is very long,
sir,
and if the 3 drugs are not working, then you have to start insulin. But this particular patient, what we are discussing is only a short duration of diabetes, hardly 3-4 years, and then he is non-compliant. Here, this particular person may do well with 4 drugs.
I will be hesitant even for 4 oral agents. After 3, I will always go for, as Dr. Venki said, either GLP-1 receptor agonist if the patient can afford it, or basically
he cannot afford insulin, he cannot afford GLP-1. So what is wrong in my thought process, sir? Why not I should not give? Why I shouldn't give? Why? See,
he's asking about the 5th drug.
Why? Absolutely agree. Why? We have to go insulin, we have to go GLP-1. Now he is not willing for both the things. But why shouldn't I give? Or why?
If 4 oral agents are not going to be effective in reaching A1C target, what is the point in adding a 5th drug? And which drug you are going to add? He is already on SGLT, DPP4, metformin, sulfonylurea. The only other option left is now pioglitazone. Because, yeah,
he is not asking the 5th one.
5th
oral drug. 5th oral drug.
What he said was, what he is asking the question is, why can't I go for 4 drug combinations?
No, 5.
No, 5th drug.
Even 5 drug also. Where am I wrong? Where my thought process is
I don't think there is any point in giving a 5th oral agent. What's the point? I don't think I will go for it. Venki?
See, as you say, a patient totally refuses insulin. You have no other I think you have the option to give the 5th drug.
Then it's a failure on our part.
Yes.
So, I remember one study which Vijayakumar sir spoke earlier.
And if you are able to bring down the HbA1c with the 5th drug, I think you are successful.
Hello. Sir, on the prescription, patient prefers OHA, that's all.
Sir.
You have to specify that.
Yes, sir.
Patient prefers OHA.
Not willing for insulin.
That's all.
Even after repeated counseling.
No, Selapandian, to certain extent we can hear to them. That is called masterly inactivity. Okay, but you need to be controlled aggression also is required. You need to change their mindset to say, we have to do that. We have to put your foot down and then say no. 4 drugs is enough, sir, and if you're not doing well, you have to go for insulin.
We can give them a lenient period of 1 week. We have to go into their situation.
No.
2 மாசத்துக்கு அப்புறம் தான் வருவாங்க சார்.
அது கரெக்ட்.
இல்ல 2 வருஷம் கழிச்சு வருவாங்க, அது வேற விஷயம். 2 மாசம் கழிச்சு வந்தா பரவாயில்லை.
Selapandian, the issue is that very one thing actually. To certain extent, we need to discuss and do that. After some time, I think we have to be firm on what you are thinking, and you need to convince them what you are thinking is right. That is the thing what we need to do that. See, in fact, the whole general understanding is if 3 drugs fail, start insulin. But here is a case where you can think about fourth drug, no problem. But if fourth drug also fails, I don't think there is any role for fifth
Sir,
drug.
one
Rather-
practical difficulty is you will change the doctor. And as he said,
Look, what happens when the other doctor also says that he is not going to give fifth drug? Obviously, he has to take
Let
the.
him go. You got better patients.
Yes.
Who will hear to you.
Yes.
Gauri, actually, if a patient comes to me and patient is already on fourth drug and he's asking for fifth drug, I normally tell, why that can be claimed only in the court of law, but it should not be claimed in the court of health.
So the point is very well conveyed by the teachers. So if you are going to start 5 drugs, rather we are going to land up with a higher HbA1c. There is one particular study which showed if you are going to add 3, 4, 5, your HbA1c is rather going to increase, not come down. So this is the message that we wanted to convey.
With this, we'll go to the. We'll just see what has happened to this patient. So we again motivated this patient. We asked him to take the dual drug combination, but along with that, we also added an SGLT2 inhibitor to this patient. Dapagliflozin was added in a dose of 10 milligram, and we emphasized him to come for regular visits. The reason why his HbA1c initially jumped up was he did not come for regular visits. There was no motivation, and that's the reason he was not compliant. So he was asked to come for regular visit, and you can see after a month, after starting SGLT2 inhibitor, the blood sugar dropped down, weight also got reduced, and again you can see after a period of somewhere around 4 months, you can see there is a weight loss of 5.3 kg and the HbA1c came down to 6.3. Again, that was, you can see persistently over the next 1.5 years, you can see weight loss of 8 kg was maintained and HbA1c was consistently maintained around 6, 5.8, 5.9, 6.1. Everything was going perfectly good for this patient. Good amount of weight loss, you can see consistently, absolutely fine, ideal HbA1c range, everything was maintained. But by the time we were thinking that we have done the job, you see this particular thing happened here. So he started having dysuria. He went for an investigation. You can see urine routine investigation showed field full of pus cells, and urine culture showed that there is E. coli with more than 1 lakh colony units per ml. So obviously this patient has developed a urinary tract infection. By the time everything was going smooth and fine, you can see he landed up in a urinary tract infection. So in this context.
So in this context, we will ask Madhavan sir.
Urinary tract infection after how long? After how many months?
After a period of 1.5 years after starting SGLT2 inhibitor. Yeah, even more than that. So yeah, it was not immediately after starting an SGLT2 inhibitor.
The jury has to tell. If it is happening, it has to be happened in the earlier initiation itself.
No, for this patient, it has happened after 1.5 years. We will ask Madhavan sir. Sir, so if it is going to be pyelonephritis, obviously we need to stop. Here the patient comes with a symptomatic UTI. We need to stop at this point of time. So if it is a vaginitis or a balanophthaitis or just a foreskin infection, so or a mycotic infection, should our approach be the same for all the patients, or few patients can be
Definitely. Whatever is the clinical scenario, I will stop SGLT2.
No, he's asking.
At least temporarily.
He's asking if it is not a urinary tract infection, if it is a simple genital mycotic infection, would you continue SGLT2 inhibitor?
No, I won't.
Or you simultaneously treat the genital mycotic infection with an antifungal and continue the SGLT2 inhibitor?
Is you temporarily withdraw SGLT2 inhibitors, treat the mycotic infections, and you are able to control it totally, reintroduce and see. That is the teaching. And in case there is history of recurrent urinary tract infection, then I will definitely will not suggest SGLT2 inhibitors. I will withdraw in this case, at least temporarily.
So
patients get adapted with SGLT2 within 6 months. That's what we have seen.
Sir, but it is not.
I don't agree with you. Urinary tract infection can occur at any time in the course, not necessarily within 6 months.
That's what, so we can treat
happen.
and continue. As you said, if it is going to be persistent, then we can stop.
Venki is an expert, SGLT.
Yeah.
Okay.
Come, you come with
No.
SGLT.
So I thought there is so much for discussion in this patient. Yeah, thank you so much. UTI initially, I think, was apprehended as one of the commonest complications. But I think our experience tells us that, yeah, it is the genital infection which is much more common. Yes, you can have, being a diabetic, nothing prevents him from having an isolated episode of UTI. But if there is going to be a recurrent UTI, as Madhu right now pointed out, then maybe you'll work up. Probably he has got a prostate, probably he has got a stricture urethra, probably he has something else. So, a treatable cause for a recurrent UTI, till that time, do not reintroduce the SGLT2, attend to it, and then you can reintroduce. So, to have the fear that SGLT2 will enhance the risk of UTI, I don't think we can subscribe to it. But certainly genital infections are there. So many cases of phimosis and tight foreskin we have picked up when the patients present, after initiating and then the circumcision has been done and you are able to, because this class of molecules are brilliant, amazingly brilliant. Disease modifying, having an effect on the metabolic effect, and maybe much, much more than what we have identified them to be effective. So let us be the last to withdraw them totally. I'm not saying blindly we will continue, unless if there is going to be a recurrent UTI, work up, remove the cause, and then reintroduce, and then totally abandon it, maybe in certain rare situations. Please be justified enough to totally abandon this molecule.
Okay, you know that I work in an institution where the urology is the biggest part. At least 2 cases of pyelonephritis every year I see patients who are on SGLT2 inhibitors. One of the biggest unfortunate thing is that most of the primary care physicians and even physicians and even the so-called qualified diabetologists, endocrinologists fail to teach the patient about the personal hygiene. They don't even tell that there is a risk of urinary tract infection. So they go around various doctors, they are treated with antibiotics, antifungal. Ultimately, they'll end up with ascending infection and pyelonephritis. I think this has to be taken very, very seriously.
Absolutely. I totally agree with you. 3 causes which I found it to be in clinical practice. Of course, number one is calculus in the ureter producing ureter hydronephrosis, number 1. Or papillitis necroticans. This is very, very common. And third thing is reflex of urine. So the advanced stages of diabetes is autonomic neuropathy. There is a certain amount of reflex. So these are some of the possible causes which could be responsible for a complicated UTI or even a recurrent UTI.
Was this patient on some kind of a modified diet or a diet replacement?
No, sir. He was not on that.
Okay, I'll give you, I'll tell you something. This 8 kg weight loss in the presence of only a SGLT2 inhibitor that is persistent for 2 years is absolutely impossible. I'll tell you why. There is, at the end of 3 months, there is usually a compensated increase in the energy intake. Right? So if this is an 8 kg weight loss that is persistent, I want to find out what is going on with this patient. Has he lost muscle? Is there something else going on? Is there latent tuberculosis? This is not possible. Or does he have, by the way, and since he's got his A1C down to 6 point, I'm wondering whether he has coexistent adrenal insufficiency, because this doesn't fit. The commonest cause of something that we miss in these patients is latent renal insufficiency. You also met latent adrenal insufficiency because somebody moving from 8.3 to 6.3 and 5.8, which is almost in a pre-diabetes range, with just these 3 drugs is unheard of. So there is something else going on in this patient.
Especially after 6 months.
Well, I agree with you. I think beautiful clinical input, Krishna. But an occasional patient. You have 100 patients, the weight loss. I have had patients on DAPA with reinforcement of lifestyle modification. You have had weight loss to the tune of about 8 to 10 kgs. That is number 1. Second is, we had a presentation in one of our journal clubs. One of the real-time cases was presented by a practitioner. Mere lifestyle modification adherence has shifted, pushed the HbA1c from 9.1 to around 6.7. So these figures are not, these are not the patterns you anticipate in every patient, correct, but it is not at all uncommon. Absolutely, your clinical input, think of something, such a huge weight loss, probably he has got some, maybe serum sodium, cortisol, whatever you need to work up in a given patient. Keep at the back of your mind, or even nothing related to your diabetes, maybe some other cause for the weight loss. So being a diabetic, absolutely the point is well taken.
I agree with you, sir.
But it is not, but it is not uncommon to witness this amount of weight loss. I have seen it in my practice.
No, I agree with you, because there are several patients who maintained at less than 10 kilos weight. In fact, one of the contraindications of it in a lighter moment is that social contraindication. Patients come and say that, sir, I am not able to face my friends and relatives.
That's the problem we
ரொம்ப
face.
மோசமா இருக்கு என் நிலைமை. Please stop the drug so that you want to put on some weight. This is what is happening actually.
I am facing
That is
this
a combined
very
effect
frequently.
of SGLT2 inhibitors and statins. Both these can modify their halagu, right? My question is, regarding the urinary tract infections, we have
Yes, sir.
innovative brands, we have generic formulations, cheaper formulations are available. Some of the trials have, some of the drugs formulations have undergone bioequivalent and bioavailability studies. So we should always think the possibility that we should not always blame this particular molecule as a cause for urinary tract infection, though it is common.
Okay, let's get back into the case, Dr. Gauri.
In this case,
Yeah.
I would like to ask a quick question. His HbA1c is about 6, 5.8, 5.9, 6.1. It is all showing a regressing trend. At this point of time, when he is on metformin with the DPP-4 with the SGLT, do we need to de-escalate the drugs? So it is, are we like with 3 drugs, are we worried about a hypoglycemia? Should we de-escalate because 5.8, 5.9? So
all the 3 molecules are not going to produce hypoglycemia. So they act in a glucose dependent manner. So I think there is no need. He is doing well. So definitely I will continue the drug. I will not de-escalate at this stage.
70 to 80 will be there in CGMS. If you do a CGMS, you can find out what is the reason.
He
No.
does, clinically he doesn't have clinical hypoglycemia.
yeah,
I don't know about
no
CGMS,
symptomatic
whether it was done.
hypoglycemia.
And clinically there is no hypoglycemia. Otherwise he is doing well. And here is a patient who have taken years together to motivate. You de-escalate now, you may again go back to poor control. Dr. Krishna wants to say.
2 points. First, I don't think there's any indication to de-escalate. Second, I would go and measure his calf diameter, check his hand grip dynamometry, check him, ask him if he can get up from a chair and walk, and make sure that he doesn't have sarcopenia that's going along. This is not, if this presentation is right, there's something that's going on in here. So you can go on in the presentation, but if this is a real patient, go back and do this. Check his cortisol, check his EGFR, check his, see if his calf is less than 32 centimeters or more than that. Check his hand grip dynamometry. By the way, please buy a hand grip dynamometer in your clinic. It's 300 rupees. It's good Chinese make. It makes a big difference. Ask him to get up from a chair and walk and see if he's able to get up quickly 5 to 6 times. Not able to do that. Remember, sarcopenia is not just when you use weight loss medication. Sarcopenia is a very, very important complication of diabetes. It's a good point to illustrate in this particular patient. The severe amount of weight loss, A1C that is not moving up after 2 to 3 years, in fact moving down, there is something else going on. As far as the UTI, you can even treat through, nothing will happen. Nothing will happen. If there is no obstructive uropathy, you can even leave the SGLT2 inhibitor on and treat the patient, nothing will happen. But this is the issue.
Dr. Krishna, sarcopenia is part and parcel of the disease. Anybody can get it with any drug, aging
Exactly.
also. But what we are trying to get from you is, are you feeling that these drugs are responsible for sarcopenia? Assuming that he has sarcopenia.
So, 2 parts. One, the one side effect that people don't talk about SGLT2 inhibitors is fatigue, right? And that's something that's very, very well known, though I haven't seen it much reported in the literature. This is one. Second, any weight loss is associated with a certain amount of muscle loss, correct? So usually if this patient is not doing weight resistant exercise, 50% of your weight loss is contributed by muscle. So, and the best way to prevent it is, we don't talk about resistance training in people. Besides the regular exercise, a lot of people run, walk, jog, cycle, they don't do resistance exercise. This needs to be part of the prescription.
No,
Having said that, I still would get an EGFR, I would still get a cortisol in this patient.
Dr. Krishna,
Thank you for that.
I agree with you very much. But we need to balance between what is the benefit of more fat loss and then minimal muscle loss. It is possible. SGLT inhibitors cause majority causes fat loss and minimally protein loss.
That muscle loss is
Lean
not,
mass,
sir,
lean
that muscle
mass,
loss is
lean
not,
mass.
not minimal at all. That's, see, what I'm trying to sort of indicate is a change in our understanding of this process. The last few years, we are learning a lot more about muscle loss and diabetes. And as an important part of it, and nice, an important part of this whole picture. All I'm trying is to introduce this particular point into the discussion, saying, as part of your evaluation of the patient with diabetes, measure 3 things. One, the calf diameter, the calf circumference, less than 32 is a problem. Measure hand grip dynamometry. It costs 300 rupees on Amazon. Keep it in your clinic. Many patients you'll find have less than 5 or 6 kilograms. Normally is around 40. Anything less than 12 is abnormal. Third, find out if they can get up. Many patients can't get up from their chair without holding, right? So all I'm introducing is when you use weight loss medications, this is a side effect that we don't talk about a lot. So while all of this is possible and nothing would have happened to the patient, I being me, I'm trying to introduce this caution into this.
No, my question to you is, are you going to say that in case he has sarcopenia, you are going to blame any one of these molecules?
I would say it has contributed it, and what I will tell
That
him
is
is
what I want
from
to
now on,
Yeah.
I want you to go to Amazon and order a system resistance band for 1,000 rupees, or get some dumbbells at home, or fill up your water bottle with water and start using it. The resistance training part prevents. Third, if you don't want muscle loss, here is a little other trick that Dr. DeFranco uses. I haven't seen it anywhere else. He just add a small amount of pioglitazone. Thiazolidinediones are remarkable for not preventing further muscle loss. So if I were to add another drug to this patient, I would add a thiazolidinedione because that will prevent muscle loss. So I'm just introducing this concept into this. It's something that we don't talk about often. It needs to be part of our discussion.
Probably also include protein at 1 milligram per kg per body weight in diet.
Yes.
You don't have to blame the drug. I mean, of course, keep the drugs in the background and then include whatever Krishna said and add protein in the diet.
Thanks for those inputs. For lack of time, we'll go into the case.
Yes.
One
last,
please, sir,
which is
please.
Very controversial thing. Now, I think, Sir Venkatraman, sir, you can answer. See, Krishna has really brought out a very, very important factor, muscle loss and other things. Now, I would like to take your opinion, if you don't mind. Take your opinion whether we need to weigh the benefits that we get with SGLT inhibitors compared to what Krishna is worried about. What do you say about that?
So I think when you have a discussion like this, I think when you have an independent view and the inputs, like what Krishna has said, it certainly at the back of your mind, because we have been proceeding on a single track of therapeutic modulation of the drugs depending upon the situations. So when you look independently, can this amount of weight loss give some warning signals to you to look for other causes which you probably do not at the time? Absolutely well taken. Now, if there is sarcopenia, if you feel there's a contribution from the SGLT2 inhibitors, still I will retain the SGLT2 inhibitors because these molecules are uncomparable, if my language is correct. Usha, language is correct? Because the consistent benefits with respect to the cardiac hospital for cardiac failure, hospitalization, CV mortality, and which drug in the world has? Unbelievable. So, in the context of this patient, absolutely your warning signals are well taken. The weight loss is out of proportion to what you normally anticipate. There it could be a certain amount of muscular weight loss. If he's already on statins and SGLT2 inhibitor, even with EMPA, I think there has been a study to say that the sarcopenia could be accentuated. Look at other aspects of preserving the muscle mass rather than abandoning the molecule.
2 points. This is a 48-year-old man, right? So I wouldn't take the SGLT2 inhibitor off, which is what I said. But if this were a 70-year-old man, right, I would be careful. So one of the points that we don't talk about diabetes is frailty. Now, if this were a frail 75-year-old, I would not start an SGLT2 inhibitor. So, for example, the SAIL, so we have two almost 75-year-old people here. For them, you could start a GLP-1 receptor analog, an SGLT2 inhibitor, any of those, right? Because they're able to maintain their body mass, their weight, their activity. On the other hand, so there are some very, very good tests of frailty that you can look it up. But I check frailty. I've started measuring sarcopenia measures in my clinic, especially now when patients come to you and ask for weight loss. I actually get the baseline calf measurement, I get the baseline hand grip dynamometry because I want people, you don't need to get a DEXA, but you do need to get at least this much about in your clinical practice. Sorry if this took you off track, but I thought this was an important part to discuss.
No.
Thanks for the wonderful input, sir.
You have taken a very pertinent thing. It's a very good food for thought.
Thank you so much, sir. Let's get back into the case. Dr. Gauri, can you start it?
So,
you got only 10 minutes.
Yeah, we can finish it before that.
So,
Sir.
Resistance band for sir. So, dapagliflozin was started in this patient. He was on back to Sita with metformin. Appropriate antibiotics. His UTI was addressed and advised frequent self-monitoring. His repeat urine culture sensitivity is normal. His fasting blood sugar is 147, postprandial 283. We don't want to start SGLT at that point of time. The patient was started on glimepiride. September 2019, his fasting blood sugar is 121, postprandial 171. Again, his controls are okay, well maintained. He continues to smoke. Still, his blood sugar is in 2000 also. It is all well under control. Now, the patient developed an acute anterior wall MI in 2021. His fasting blood sugar is 134, postprandial is 196. He was on sitagliptin with metformin, glimepiride 1 mg, he was taking 2 times a day, voglibose. This is a stage where absolutely we need to put the patient on SGLT. He was seen by Dr. Prabhakaran yesterday, who was advocating SGLT for heart failure. So, and he said, go and meet Dr. Rajesh. He is your treating diabetologist. On his consultation, you can start SGLT. So, what did you do, Dr. Rajesh?
So probably we have to see. So initially we had inhibitions on restarting SGLT2 inhibitor because we had the fear factor in mind about UTI. But again, you can see after a period of 2 years, this patient remained free of urinary tract infection. We have to rule out whether this patient is having any risk factor which is going to cause urinary tract infection, whether he has a prostate, whether he is having any stricture urethra, whether he is having any renal calculi. If you are going to look into all these risk factors, if it is not there, and again, if the patient is remaining urinary tract infection free for at least 1 year, here in this patient, he has remained at least for 2.5 years. Obviously, if not for glycemic control, it is already good with the other drugs, but for cardio protection and renal protection, obviously we have to start SGLT2 inhibitors. Your inputs on this, sir. Obviously, we have to start SGLT2 inhibitor here. Probably we can remove any one drug because here the HbA1c is already under control.
Why didn't you start it earlier? In August?
We could have started earlier. Imagine this patient was little apprehended in accepting it because he had suffered an urinary tract infection. In spite of telling him that you had a good amount of weight loss, in spite of telling that you never had hypoglycemia, and all these things we have explained, but patient was reluctant to accept at that point of time. But now compelling indications are there.
We were
now
also
this patient,
hesitant, sir. We were also, since he had a UTI, we were also hesitant to start.
But now the indication is there. He is having an established cardiovascular disease. Obviously, this drug has to be inside the prescription. So, can we remove any one of these drugs and can we start him on an...
We are talking only about ASCVD or failure also.
No, this particular patient, obviously you can see the ejection fraction, maybe it was done during an episode of MI, probably the ejection fraction could improve, that is a different story. He's already having LVF also.
The cardiologist he was also skeptical, sir. So he also didn't want to take the risk since he developed a UTI way back. He was a symptomatic UTI. So he said, he threw the ball in Rajesh's hand. He said, like, you go and manage with him. So he was seen by Dr. Prabhakaran. So
it is an imaginary case.
So I'm going to again play devil's advocate here. One, I would have see, the thing is that here is someone, I would have not stopped the SGLT2 inhibitor. I would have continued with SGLT2 inhibitor because it was a single urinary tract infection. I would have treated through the patient. If there were recurrent UTIs, then I would stop. This is one.
Sir, a small intervention, sir. How early should we restart, sir? The patient developed a symptomatic UTI, he was treated on antibiotic, his culture sensitivity was negative.
Nowadays, I don't even stop. That's what I'm coming to. Nowadays, I don't even stop.
For a urinary tract infection?
For a simple cystitis that does not have pyelonephritis, I don't stop.
Sir, it is not a cystitis, it is a symptomatic urinary tract infection.
When you say symptomatic, you said dysuria. There's fever.
No, sir, he had a E. coli count of significant count was there.
See, if it is less, okay, I'm going to challenge again. Less than 10.10, anything less than 10 to the power of 5 colony forming units of E. coli is not even a UTI. That's a commensal. Okay, so it's a UTI.
It is more than 1 into 10 power 5 male
Correct,
patients.
Second, there is no evidence of pyelonephritis, right? Is there evidence of pyelonephritis?
No, it was not there.
It was a cystitis. It was pyelonephritis, there would have been systemic symptoms. There would have been CV angle tenderness. So one, I would not have stopped the drug. See, what you've done is great. I'm just giving you alternates. Second, I would not have started on glimepiride. Here's somebody who's lost weight. I would have just put him on pioglitazone. That's different. Third, one of the tests that I do get in patients who have long-standing diabetes now is an NT-proBNP. An NT-proBNP is a great initial screen rather than an echo to find out if they have coexisting heart disease. Third, when they've developed an acute myocardial infarction, I don't need an A1C of less than 7. I needed 7.5, right? So I would have first offered this patient a GLP-1 receptor analog. That is standard of care. If the patient says I cannot afford that, I would have documented it. But this patient needs to be on a GLP-1 receptor analog that prevents further MIs, at least reduces the incidence of further MIs, and he needs to be an SGLT2 inhibitor. If you look at it, he has an ejection fraction of 46%. This person needs to be, this would not be a new phenomenon. He needs to be an SGLT2 inhibitor, he needs to be on a GLP-1 receptor analog. If possible, he needs to be on, this patient needs to be on a beta blocker, he needs to be on other drugs. But an ARNI, absolutely. But most importantly, the SGLT2 inhibitor needs to get on board immediately.
Unfortunately, what is ideal is not practical very often.
Absolutely.
So we have to be more practical for the primary care.
Sir, but it's not ideal, sir. It's guideline based.
I understand.
This is guideline based care and it's possible. At least we should offer the patient the GLP-1.
How many patients in our country will accept GLP-1 as a agonist, considering the price factor?
Considering 20 years ago, a lot of patients, and if they know that it helps them, they do.
Still, it is very small percentage of patients.
Sir,
it's very difficult, no?
Sir, what I'm
Maybe
saying,
in your practice, you get patients who from IE and other. But in my practice, I get patients. Somebody said yesterday some Kupusami or Rikshawala. I cannot go and prescribe.
So even if it is, sir, all I'm saying is, even if the Kupusami is a Rikshawala, right? I think my job is to not judge whether he can do it or not, but to offer it and say, this is the best drug for you to be on. But it is expensive. If you can't take it, these are the alternatives.
He obviously can't take it.
Sir, all we can do is we can only document that he is not affordable.
The question is, have you discussed it with the patient? And the answer is, I have discussed with the patient and he can't afford it, should be really the way to look at it. But certainly, in somebody who's got an ejection fraction of 46%, who's post-MI, glimepiride is probably not the right drug. I would not have kept a sitter also on board.
Not at this stage. I will never endorse glimepiride. But SGLT, yes, definitely. If the cardiologist feels the patient is in heart failure, definitely. In spite of the fact that he had one episode of urinary tract infection.
No, actually, Dr. Krishna, actually, even when the SGLT inhibitors were expensive, me and Samit used to do what used to do is we take a half tablet. Samit, we used to do that. Half a tablet. To reduce the price. Yeah.
So,
you may not like it. They were doing and we were accepting it. That's what I'm trying to say. Remember, we had a discussion.
Yes. So, what he said is very, very correct, sir. But practical things, this patient was not reluctant. This patient was reluctant to accept it. That's the reason SGLT2 inhibitor was not started initially. But now there is a compelling indication. This patient has an established cardiovascular disease, so we have to start him. So what we have done is that you can see glimepiride was removed from the prescription and it was replaced with a dapagliflozin. Everything was going well. You can see the HbA1c came down, consistently it was maintained, and again for a period of, everything was maintained, but again what happened? We always have several doctors in the patient's family. all obtained a degree from Google University, YouTube University, all those people are there. They told him all your problems are only because of the drug. They asked him to stop the drugs. He readily accepted it and he stopped all the drugs and he started taking native medicines, especially from unauthorized persons. And you can see he started taking OTC herbal products, touch therapy.
He underwent some touch therapy, which is very specific to Dr. Rajesh.
No, it is there everywhere in Chennai.
Next to his clinic, there is
Yeah,
a touch therapist.
yeah,
Can
obviously.
I ask a question, please? Why DAPA? The guideline is very clear for
No, now the reason is,
not
it has become off-patented. Now the reason is, in 2021.
Can I interject? It
Yeah.
can be off-patented. The
Yeah.
guideline says for ASCVD, it is not DAPA and CANA. It is only EMPA. So why DAPA?
The simple reason
What
is,
the patient can afford, sir. It was not generic at that point of time.
even now it is not generic. Only DAPA is generic. Cost factor.
Available generic.
So what do you think would have been the cost of the OTC herbal products?
Sir,
So even if it is 10 times, they are ready to accept herbal products because they think it is natural, nothing will happen to them. That's the concept they have.
Touch therapy is free, no?
No, 100 rupees. In my area, it is 100 rupees. So,
Rajesh is going to give the touch. I don't know where he's touching.
so obviously, he stopped all these drugs. You can see the fasting, postprandial, HbA1c, everything jumped up. And you can see when we evaluated, this patient had a creatinine of 1.68, and you can see fundus showed a non-proliferative NPDR was there, and you can see UACR is elevated, EGFR has dropped down to 45, and what you can see is that this patient has landed in a stage 3 kidney disease. So this is the, and you can see the journey actually continues. We can continue the journey. It is a never-ending journey with the type 2 diabetic subjects. As long as we are there, as long as the patient is there, this journey will continue. But unfortunately, to lack of time, we have to stop this journey. Over to the chairpersons. You can give your final comments and we can conclude the session.
Only thing I would say that, excellent. Thank you, both of you, for bringing this case. And most important thing is that it was able to instigate discussion, the heterogeneity in discussion.
Yes, sir.
No, ultimately, finishing touch is given by Krishna. That's very nicely.
You want me to give one more finishing touch?
No time.
but I'd like to make one comment for us before we go home, and that is this. This is something I heard from John Topman. The most cost-effective way to practice medicine is to do the most appropriate thing first, right? The most cost-effective way to practice medicine is to do the most appropriate thing first. We should judge what is the patient's disease, but we should not judge the patient's values. That's a call that they have to take. These are 2 points I'd like everybody to take. We should not say it's practical or not practical. The patient should say it's practical or not practical. Thanks.
Thank you. And Gauri and Rajesh, thank you very much for bringing. And I think Dr. Venkatraman should also be thanked for giving this, taking this actually. And fantastic points, always Dr. Anand Moses gives a discuss panna. Thank you. And Madan, as usual, sir, a wonderful person. And thank you very much for all. I hope you all enjoyed it actually.